Hi, sir. Thank you very, very much for joining us today. I can see you. Hi, sir.
Good morning.
Good morning, sir. Thank you very, very much for joining us today.
You're welcome. You're welcome. My pleasure.
Thank you so much, sir. It's a pleasure to have you here with us today. We are also excited to have you with us to deliver such an important lecture today for spinal vascular malformations.
Thank you. I keep getting a notice to put a username and password, you know.
Sir, in Zoom?
Yeah, I don't know.
I will have to say.
Okay, it's gone. So hopefully it'll be fine. Let me share my screen and let's make sure that everything
is working. Yes.
Can you see my screen?
Yes, sir. Perfectly.
Okay, let's see. There are some videos. Let's see if is the video showing well?
Yes, sir. Sir, it's great.
Okay, good.
Thank you.
Do you see this this sign that popped up this on my screen?
No, sir.
Okay.
No, sir.
Okay.
But your screen is currently not in the slide share mode, so probably you would like to make it full screen by turning on your slide share.
Yeah.
Yeah. So otherwise, it's totally perfect without any lag or something.
Okay.
It's amazing, sir. Thank you very, very much, sir. It's a very important topic. We had Professor Spester about 2 months ago, and he was also discussing about the spinal arteriovenous shunt and everything. And he was saying that it's certainly a very important topic to discuss. And sir, I've myself seen and received and also read case reports on patients who have been misdiagnosed with having the dural AVFs and things like that. So I think it's a very important topic to discuss all these malformations and everything to make everyone quite aware of these. So again, thank you very, very much for joining us today. And of course, sir, you do not need any introduction, but I will certainly, I showed a couple of slides when I launched the meeting to introduce you. So obviously, most of us who are interested in neurosurgery, especially in vascular surgery, or most of us know you very well. And I remember that when I was a resident, I used to watch your webinars with neurosurgical.tv, and those were very, very amazing. So again, thank you very much for joining us.
Thank you. Great to be here.
Thank you so much, sir. Sir, the right time is about 8 minutes from now, but if you like, then we can just start the meeting. I know you've got a very busy schedule, so I don't think we should keep you waiting.
No, I'm fine. We can wait until I just wanted to connect a little bit earlier to make sure that everything is working well, so we can wait a little bit. Yes, so tell me a little bit about this series.
So actually, I have launched this platform, the Neurosurgery Enthusiastic Women's Society. So this is not, it's one of a type because it's not only for women neurosurgeons. It is open for both men and women, and we welcome all our male colleagues and seniors and friends and juniors, even the medical students as well. So I launched a couple of series that includes a master webinar series that I have just launched and a vascular neurosurgery series that is I launched it about 6 months ago. So in this series, we usually invite one of the eminent neurosurgeons, vascular neurosurgeons, to share any topic which they really like to share and discuss, something of their personal interest and expertise that they would like to share. In this series, only famous neurosurgeons like you, they just deliver a lecture, only one speaker per series. It's about, say, 1 hour long, or how longer is up on the speaker. that's why we just keep one speaker for this series. So they just deliver their lecture, and after the lecture we take up the questions in the chat box and discuss it and have a little discussion with this series. So it's like that, and it's quite popular among the peers because people really like it, since they have chance to meet people like you, the neurosurgeon, the master, then learn directly from the masters. So it's like that. Most of the time, we had the first lecture we had was with Professor Musabaskaya, and after that we had Professor Jean Oliveira, Gigi Oliveira. He delivered a lecture on eruption aneurysms, and followed by Professor Robert Spessler. He delivered a lecture on the AVMs, and we had lecture on brain cavernous malformations by Professor Michael Lawton, and there is also a lecture. There will be a lecture soon with Professor Bernard Bendock from New York Clinic again. So it's like a series where there is lecture by only the masters of vascular neurosurgery, and they deliver and share their personal views, show videos and everything, and people really like it. And of course we owe people like you a lot, because we have the chance to learn from masters like you. So it's like that. And the other series, the master neurosurgeon series, that's being launched by me a few days ago. In that master of neurosurgery series, we also invite the most famous neurosurgeons, and currently we've got Professor Miguel Rice for that master series. He's delivering lectures on skull by surgery, and we have got 2 lectures. We've already conducted 2 lectures from him, and there will be a 3rd lecture next month. So it's like that, just one speaker, specific series, and they deliver their lectures, anything that they would personally like to deliver. And we have just an hour long sitting with them. So it's basically a one-to-one type of interactive series that delivers which gives us a lot of time to interact and learn.
Very good, very good.
Thank you.
Great initiative. Happy to be part of it.
Sir, honor is all ours. And I think that we owe you a big thanks, because you spare time from your very busy schedule. So it actually means a lot, and it is basically the dedication of teachers like you. And I think it is because of people like you that neurosurgery is still thriving. It's a competitive and a very difficult field. People are, I guess, joining us still in this series. So I guess that vascular neurosurgery needs a lot of this emphasis, basically a little more focus for people to get to know about it, because we've got this endovascular procedures available right now, and I think that people are more going towards picking up endovascular procedures instead of surgery. So I think it's very important for especially people of my age to learn about all the perspectives to treat vascular lesions and complications, all these things that should be dealt with, which should be actually decided by the neurosurgeon. And I think hybrid neurosurgeons are quite rare, not very common, and I think this is quite important to discuss. I hope that it will be beneficial. Sir, I guess that if you like, we can start the webinar so that I think most of the attendees will keep joining us during the webinar.
Very good.
Yes, sir. So I guess that if you like, you can just go ahead. I just give you a very little brief introduction because I don't think that you need any introduction. Everyone knows you quite well, and actually, we are all quite big fans of yours. So, but for the sake of formality, I would like to introduce Professor Giuseppe Lanzino. He's the professor of neurological surgery at Mayo Clinic, Rochester. And as we all know, he has got special interest in cerebrovascular surgery, in vascular surgery. And he has written about 600 articles and different papers, and also has authored 4 textbooks. So it's a pleasure to be here with you, sir, and to welcome you in our humble series on vascular neurosurgery. And I think that it means a lot of us to have you with us and to have this privilege of learning from you. So again, sir, welcome to our webinar.
Thank you very much for the invitation and the very kind introduction. It's a pleasure for me to be here with you all to share some concepts about vascular spinal lesions. I know that in the same series, Dr. Spetzler in the past has covered the same topic, but I thought that it would be nice to just to look at different aspects and get a different perspective and repeat some of the concepts that have been already very eloquently covered by Dr. Spetzler in the past. So spinal vascular lesions are uncommon, but they are an important cause of potentially fixable, correctable myelopathy. And I will show that maybe some types that were considered quite uncommon in the past, they might be becoming more common nowadays. We all like classifications in medicine because I think classifications are important in the sense that they put everything in a more organized fashion, and they allow us to communicate with each other and to understand exactly what we are talking about when we refer to a specific lesions. Years ago, when I went through my own training, classification of spinal vascular lesions was quite confusing. And when there were classical classifications in 4 different types that did not have really a good rational basis. When we think about arteriovenous shunts, a classification that makes much more sense and that has been popularized by Dr. Spetzler, it's a classification that that classifies the arteriovenous shunts in relation with its relationship with the spinal canal. So we will have extradural or epidural shunt, dural shunt, PL arteriovenous fistulas, and then proper parenchymal arteriovenous malformation. And when we consider vascular lesions other than arteriovenous shunts, then we can include also cavernous malformations. And I will try to show examples of each. This is a summary of about 5 years ago now. We tried to organize our series. You can see that the most common type of spinal vascular malformation is the so-called dural arteriovenous fistula, and therefore, since these are more common, we'll spend a lot of time on them. But as you can see here, there is the epidural type that in our series already 5 years ago, was constituted about 23% of the arteriovenous shunts. And I will try to suggest that this particular type, the epidural arteriovenous fistula slash AVM, that was considered quite uncommon in the past, might becoming more and more common. When we look at the distribution of the different vascular malformation, and I think this slide says something that might have a lot to do with the etiopathogenesis of these lesions. We see that in blue, the dural fistulas are more common in the thoracic spine and less common in the lumbosacral segment. And when they are found in the lumbosacral segment, usually they involve segments of the spine like L1 and L2, L3, and less commonly like L4 and 5 that are more mobile segments of the lumbar spine. On the contrary, the epidural arteriovenous shunts, they are exceptional in the thoracic spine, and they become much more common in the lumbosacral segments, and in particular from L4 down to the sacral segment. So there is this inverse distribution between the dural and the epidural that, as I said, probably has something to do with the different etiopathogenesis of these lesions. When we consider the properly defined dural arteriovenous fistulas, they have a very specific demographics, in the sense that patients with the spinal dural AV fistula are often men in the 7 to 8 decade of life. So as I said, there is a strong male predominance of these lesions. And once again, they are more commonly located in the thoracic segments of the spine, and they are exceptional in the cervical spine, especially if we exclude those dural fistulas at the level of the craniocervical junction. So again, the spinal dural AV fistula properly defined, they are not in the cervical spine except for the craniocervical junction. The thoracic location is by far the most common. And as I said before, when they are in the lumbar spine, you can see in our series, the vast majority are in the L1 through L3 segments, and much less common in those segments like L4 and L5 that are more mobile. So here we are talking about spinal dural AV fistulas that were also the so-called type 1 of the older classification. And in these cases, the shunt is at the level of the dura, or as Dr. Spetzler says, it's immediately intradural. And you can see here in this schematic drawing, the key of the surgical treatment is to open the dura. You identify the arterialized vein, which is often located in the dorsal to the ipsilat, to the corresponding pedicle, and the treatment consists in the coagulation and division of the proximal portion of the dural arterialized draining vein. From an historical perspective, and that should teach, there are a lot of young colleagues following this seminar. From an historical perspective, not too long ago, we thought that the best treatment was doing multi-level laminectomies and stripping all of these veins from the dorsal aspect of the cord, with the result that a lot of these patients were much worse after surgery. And it was Lindsay Simon from Queen Square, among others, intuition that the pathology is the communication between arterial vessels and the draining vein, and by just interrupting the draining vein, you can solve the problem. So a very elegant and simple solution to a complex problem. But this is something that did not become common knowledge until the late 80s in neurosurgery. So here we can see a patient that has had the prior onyx embolization, but the fistula is still alive. And you can see that when you expose the dura in the lateral aspects of the dura, you might see all these arterial vessels converging into the dural leaflets. But this is not the treatment should not be centered on the extradural side. The treatment is instead centered on the intradural side. Once you open the dura, after you see a few, you recognize immediately the pattern. You open the dura and you recognize the large arterialized, thick, early draining vein, which in some cases has also calcifications at the point of its emergence from the dura. And again, here it's another example. Here you open the dura, you see the large arterialized vein emerging from the dura, usually dorsally to the corresponding pedicle, parallel to the underlying nerve root. And here is a temporary clip placed on the arterialized draining vein. And you can see that after placement of the temporary clip, there is discoloration and the distal, after several minutes, the distal portion of the vein turns blue. Another example, opening the dura, and you see the large arterialized draining vein emerging from the dura, usually in the posterolateral aspect of the dural sac. And here is that after separation, you can see the relationship of the draining vein with the corresponding nerve root. So how is it possible that such a relatively small anomaly can cause quite a great derangement of the function of the spinal cord? And the pathophysiology is related to venous congestion. It's an ascending myelopathy. And if T2 changes, this is important. So some characteristics, patients are usually men in the 7 and 8 decades of their lives. If there are T2 changes on MRI, since this is an ascending myelopathy, and therefore the most dependent, the most distal areas are the ones that suffer the most. If there are T2 changes on MRI, characteristically, but not always, these T2 changes extend all the way down to the conus. And this is a typical case. They are not always like this, but you can see T2 changes with the swelling, expansion of the cord, and on T2, presence also of the characteristic flavoids, which usually are more dilated on the dorsal aspects of the spinal cord. Now, over the years, and then once you see a lot of these patients, you start making some correlations. Over the years, we have noticed that almost consistently, a patient with the spinal dural AV fistula, which are often at the beginning, they are misdiagnosed for transverse myelitis, and therefore they receive high-dose steroids. A large proportion of these patients, if they receive high-dose steroids, they actually have a worsening of their function. And that's a little bit counterintuitive because naturally we tend to think that steroids are beneficial in patients with spinal cord edema. But in this particular case, they are actually contraindicated. And you can see in our series at that time, more than 50% of patients who were treated with high-dose steroids suffered an acute deterioration shortly after administration of steroids. And once their deficit worsened, they did not always improve after the steroids were discontinued. So how is this possible? Well, we think that the mechanism of this paradoxical worsening after high-dose steroids is related to the fact that you have increased intravascular fluid retention after administration of steroid. And therefore, in a patient where the pathophysiology is related to venous hypertension, you can induce acute worsening of their symptoms. Now, this busy slides is to show that at the beginning, the clinical diagnosis, it's quite difficult because a lot of these patients, they present with the signs and symptoms which might mimic the way more common degenerative disease of the lumbosacral spine. And you can see here that a lot of these patients at the bottom received additional intervention before correct diagnosis, including surgery, for reasons that in retrospect were not related to not for reasons, but for pathologies that were not related to the fistula. And this is a patient that you can see was seen in a very good center with patient presented with sensory symptoms and progressive weakness aggravated by exertion. And you can see this patient as these patients in this particular age group often have multi-level degenerative disease with spinal stenosis, underwent a great decompression without improvement. But if you carefully look at this MRI and you look at the conus, you realize that in retrospect there were already changes in the conus, obviously not, which is not a characteristic findings in patient with advanced degenerative disease of the lumbosacral spine. So a practical trick is that when you see a patient and the symptoms are not 100% typical for spinal stenosis, always look on the MRI at the conus. And if you are in the presence of that rare patient with the spinal vascular arteriovenous shunt, you might pick up some changes at the level of the conus. Catheter angiography is always and remains the most important tool in the diagnosis, despite a lot of advances in non-invasive imaging. On the angiogram, you like to see not only the level of the fistula, but you also, since these fistulas are more common in the thoracic and upper lumbar segments of the spine, you want to make sure that before you embrace in any type of treatment, you have a good depiction and understanding of the anatomy of this of the vascular anatomy of the spine, and in particular, you like to know where is the origin of the artery of Adamkiewicz. And in this particular patient, what happens when you go and do the spinal angiogram? You notice that the Adamkiewicz, you follow the Adamkiewicz down, you notice that it's a little bit more prominent that you would expect otherwise. And if you follow down all the way, you see that this particular patient that I show who had undergone a multi-level decompression elsewhere turned out to have what's called an arteriovenous fistula of the filum terminale, which is a specific, well-defined type of arteriovenous shunt at superficial. And let's see if we have, I think we have a video, this particular patient. You can see re-exploration through the prior laminectomy and identification of the area where there is that direct connection between the anterior spinal artery, which at that level fuses with the artery of the filum terminale and the vein of the filum terminale, ICG fluorescent, which is helpful in these cases to identify the actual point of connection of fistulization. You can see the artery and the vein running parallel here, and under the microscope trying to separate the artery from the vein before definitive interruption of the fistula and closure. You can see here there is a plane of separation between the artery and the vein. And once you identify the actual point where the artery, these cases, there is a direct connection between artery and the vein, then you can coagulate and divide the point of fistula. Now, these are some rare presentations. Interestingly enough, spinal dural fistulas, they almost never, I would say, or exceedingly rarely can present with the hemorrhage. The presentation, despite these dramatic changes of the draining venous system, the presentation, it's never hemorrhagic. It's almost always related to a congestive myelopathy. In rare cases, these changes of the venous return, they can result in the formation, like in this case, in the formation of a syrinx. And like you can see in this patient, and this is the typical dural AV fistula T6 in this particular patient who underwent surgery. And you can see that after correction of the fistula, there is resolution of the syrinx. So in rare case, a syrinx can be an aftermath of the venous congestion caused by the dural arteriovenous shunt. So you can see the pre-op, the syrinx, post-op improvement of the syrinx, the compression of the syrinx after just a simple ligation of the dural AV fistula. Sometimes it can be, as I said, these patients are often in the 7th and 8th decade of life, and they have marked atherosclerosis of all their vessels. And it can be quite difficult to identify the level of the fistula. So non-invasive imaging like MR angiography techniques or CT angiography has a very important role in the diagnosis of these lesions, even though I feel that the gold standard is still catheter angiogram. What these tests are very important is because they allow you to identify in the majority of patients within a narrow range the location of the fistula, and therefore when you start the angiogram, instead of starting from the intracranial compartment and walk your way down, you can start on the area of interest, diagnose the fistula, focus your attention there, and then always complete the catheter angiogram to include all the other levels above and below the level of the fistula. So that's an important role of MRA. And we talked about spinal angiography, catheter angiography, that is important to visualize and define the pathology, localize the level of the anterior spinal artery. And when you do, nowadays, there is a lot of these cases we might consider embolization, but it's important that if you do so, you obtain a microcatheter super selective catheterization with a forceful injection, because there are quite often very small vessels, usually posterior spinal arteries or posterolateral spinal arteries, which are fed by the same pedicle. And if you use embolic agents like glue or onyx, even though these vessels might be very, very small, they always form an anastomotic network on the PL aspect of the spinal cord, and therefore, with the liquid embolic agents, we say they connect the dots, and you might end up with the major complication if you don't recognize the fact that some of these pedicles feeding the fistula might also have a small contribution to the spinal cord. As I said, the spinal catheter angiography, especially if you don't do a lot, it's not easy in this patient because of age and atherosclerosis, and the visualization is not always great because you have overlying bowel movement, patient motion, and bowel gas. There are modern non-invasive techniques that are very useful, a so-called dynamic CT angiogram done at the time of the angiogram can be very useful, because in this case you can see the fistula, but more importantly you see the fact that there is a posterior spinal artery. You can see that emanates from the vascular pedicle at the same level of the fistula, and therefore this is a contraindication to embolization. What happens when you cannot see the fistula on formal catheter angiogram? If your level of suspicion is high, then you should repeat a catheter angiogram under general anesthesia. And in some patients, we have done even a third angiogram where we thought we were convinced based on clinical findings, MRI characteristic, the patient had the spinal vascular malformation. Multiple angiograms can be necessary, and a very careful analysis of each injection. But in some patients, you might still not see the fistula. And what we have done in the past, in some of these cases, we have done a PC Fiesta MRI sequence similar to the one that is obtained in patients with trigeminal neuralgia to identify, to demonstrate the neurovascular conflict. And on the Fiesta MRI, you get this myelographic effect. And what we look for what we call this hook. Basically, we look for that point where the arterialized draining vein emerges from the dura, like in this patient. And this is the patient in question. You can see he had a long-standing high thoracic dural AV fistula. You open the dura, you see the congested looped veins, and then here you can see here particular the classical draining vein emerging from the dura, which in this patient had a lot of thickening and calcification because of the long-standing nature of this fistula. Treatment, when we talk about spinal dural AV fistula, you have surgical and endovascular treatment. Ligation of a spinal dural AV fistula. This is a patient presenting with the classical symptoms and radiological finding. The angiogram fistula is at the level of right T12. You see the origin of the arterialized draining vein. Here is the arteriovenous shunting. And then everything converges into this draining vein, which emerges from the dura at the level of the pedicle. And you can see in this patient, the anterior spinal artery emerges from the dura at the contralateral corresponding level. So this is the fistula on the right, and on the left is the anterior spinal artery. And you can see again, you can center your small dura opening center at the level of the corresponding pedicle. Now we don't even open the arachnoid over the spinal cord. We go directly to the point of fistulization, isolate the proximal segment. You can see here of the arterialized draining vein, and then separate all arachnoidal adhesions, make sure that there are not bystanders, innocent veins, or very small arteries that often run along with the nerve roots. Here in this case, you can see there is an innocent small bystander vessel. And once we have isolated the pedicle with the low power bipolar, we grab it, lift it so that you minimize the risk of spreading of the current. And with the low power cautery, you coagulate and then cut close to the point of emergence, making sure that you have a decent coagulated stump, both proximally and distally. And this is the MRI 4 months later. And if you compare with the you see that there is resolution or improvement of the T2 changes. And on the MRI postoperatively, if you see resolution of the flavoids, there is no need to do an angiogram, because that's, we have found, it's by far the most sensitive expression of a treated fistula is the resolution on the postoperative MRI of the flavoids. The T2 changes, they tend to improve, and you can see how the spinal cord, the swollen spinal cord, diminish in size on serial MRIs. The T2 changes, they tend to decrease and resolve at the top levels, but they might linger for a long time. Here is just a small trick that a lot of these fistulas are in the mid-thoracic spinal cord. And in order to have a good and easy intraoperative localization, what we often do, so there is no question, we often leave a marker, usually a coil, or we ask the radiologist to put a marker under radiological guidance, so there is no question intraoperatively where is the fistula. And also you can do, as you saw, a fairly small laminectomy or hemilaminectomy and very focused dura opening. Surgical treatment is very effective with a high degree of complete obliteration of the fistula. And we talked about the imaging factors that may affect prognosis, and the fact that by far the most important marker that the fistula has been successfully obliterated is the regression of the flavoids. Now, we'll shift gear a little bit and talk about the epidural arteriovenous shunts, because in the past we thought that epidural arteriovenous shunts were extremely rare. But what we have learned that they are not so uncommon, and it is possible that either we diagnose them better, or that indeed their frequency is increasing. And one of the reasons why they might be increasing, because an epidural arteriovenous fistula can be a delayed complication of prior spinal surgery. They can be classified in direct simple arteriovenous shunts, involving where the shunt is in the epidural vein, or they can be paraspinal AVMs that because of the secondary changes of the adjacent venous compartments, they can secondarily involve the epidural space. The hallmark of an epidural fistula, unlike, because a lot of these epidural fistula, in this case, they can have retrograde intradural venous drainage, but the actual point of fistula is in the epidural space, and the hallmark is this venous pouch in the epidural space. And then there is a secondary retrograde involvement of the intradural vein through the foraminal vein. Here it's another example. The shunt, usually these are higher flow shunts. The shunt is at the level of the epidural space, and then only secondarily, indirectly, there is intradural venous drainage through involvement of from the ventral epidural plexus to involvement of the foraminal vein. You can see how nicely that vein wraps around the nerve root at the level of the foramen, and then continues in the dorsal intradural vein. These epidural fistulas can be easy to miss, especially if you don't do a close analysis of the internal iliac system, because the majority of these fistulas, as we said, they involve either the lower lumbar segments or the sacral segments. So ilioinguinal supply or lateral artery supply is usually the hallmark of these fistulas, and we have seen definitely several cases where the diagnosis was delayed because the internal iliacs were not properly injected or analyzed. So lack of adequate analysis of the internal iliac system is today still a relatively common reason why some of these fistulas might not be properly recognized in a timely fashion. The pathophysiology of this epidural AV shunt, if there is secondary intradural venous drainage, is not much dissimilar from the most common properly called dural AV fistulas. And in other cases, the pathophysiology and the symptomatology can be related to compression from engorged veins, like in this patient who had developed a disabling radiculopathy months after prior spine surgery. And you can see that there is a large foraminal vein seen. There is congestion of the epidural veins in also on the MRI. And in this case, the pathophysiology was from compression of the corresponding nerve root. On the angiogram, there is this large arteriovenous shunt with the venous pouch and involvement of the adjacent venous plexus. This patient was treated with direct endovascular closure of the shunts with coils. We have noted that there is an association between spinal vascular arteriovenous shunts and spinal dysraphism. So in an adult patient who is having progressive myelopathy and has a history of spinal dysraphism, always carefully look at the MRI to rule out the possibility, like in this case, patient with the low-lying spinal cord, it does have an associated arteriovenous shunt of the epidural plexus. Here is another example of a patient with the tethered cord and diplomyellia, and is having progressive symptoms. There is a prominent vessel. We did the angiogram, and indeed this patient did have an epidural arteriovenous shunt, which was responsible for his symptoms. Unlike the dural AV fistula, where we prefer surgical treatment, for the epidural, recognizing an epidural fistula and differentiating it from the more common dural fistula, it's very important, because the epidural fistulas, they are ideally and effectively treated with embolization, while for the dural AV fistula, we still recommend surgery, at least in our institution, for the majority of patients. I'll show you now quickly some, before concluding, some cases. This is different of lesser common types. This is a perimedullary arteriovenous fistula. This patient presented with sciatica from compression of the sciatic nerve at the level of the cono-cauda from this perimedullary arteriovenous fistula, which are typically located at the level of the conus. And here you can see a laminectomy. You can see there is hemosiderin stain of the conus. And here we are trying to identify these fistulas. They often have a prominent direct arteriovenous shunt coupled with the nidus, which is often on the surface of the conus. So in this case, we are trying to separate identify the actual main arteriovenous connection, separate these prominent varices from the nerves, and then after identification of the shunt, coagulation of the dilated vein, decompression of the nerve. In this patient, since she did not have symptoms related to compromise of the conus, we did not chase. You can see there is a small nidus which goes inside the conus. And this is a hallmark of these perimedullary arteriovenous fistulas that here is the intraoperative Doppler. They often have combined prominent direct arteriovenous shunt and a small nidus, which is usually not truly embedded into the conus, but it's really stuck to the PL surface. This is another different case. This is a proper cervical arteriovenous malformation, not dissimilar from the ones that we see supratentorially. And here, sequential multiple ICG fluorescence runs are very important and useful in allowing recognition of the feeding arteries as they are going into the spinal vascular malformation, and as eloquently showed by Dr. Spetzler, with the patients, and very carefully, you can usually coagulate, divide this vessel, and separate the bulk of the arteriovenous fistula from the remaining spinal cord. So you can see here the concept of sequential ICG fluorescence to identify the feeding arteries and progressively. That's another thing that differentiates these things from the supratentorial AVMs. As Dr. Spetzler has shown, you can actually remove this spinal cord arteriovenous malformations in a piecemeal fashion by identifying the feeding incoming artery and progressive disconnection and ligation, as it was done in this case. And you can see the final angiographic ICG that does not show any evidence of shunting. And before concluding, I will show you a case of a cavernous malformation. Cavernous malformation, of course, it's a vascular malformation of the spine that they're not dissimilar from the ones found in the supratentorial compartment. But of course, it's a different type of vascular malformation, so should be characterized and classified apart from the true arteriovenous shunts. So this is the video We did a posterior laminectomy. We are opening the dura. I like to open the dura separate from the underlying arachnoid. You can see through the arachnoid the cavernous malformation, which likely in this case came to the surface of the dorsal aspect of the cervical spinal cord. I open the dura, I open the arachnoid along the midline, tuck the arachnoid, and then try to approximate at the end of the procedure the arachnoid in addition to closing the dura. You can use these arachnoid bands, which to mobilize a large vein on the surface of the cord. So you can see there, we don't need to sacrifice. This is the electrode from the D-Wave, which allows real-time feedback about motor function, identify the portion of the cavernous malformation which comes to the surface, opening the pia, emptying those portions of the cavernous malformations where the caverns are filled, like you can see here, with subacute, acute blood, and then identify the plane of cleavage and carefully separate the cavernous malformations, which is like a cauliflower. Carefully separate the cavernous malformations from the surrounding structures, from the hemosiderin stained gliotic parenchyma. This is important to be, you see, you can preserve this vein and mobilize it as you define the boundaries of the cavernous malformation. And it's important here to be very patient. At the beginning, a cavernous malformation might feel extremely stuck to the parenchyma, but with patience and careful attention and microsurgical techniques, you are eventually able to identify and separate a plane. I love these forceps that have round teeth of 1 millimeter of diameter. And here, piecemeal removal of the cavernous malformation under the microscope. As you preserve the planes, you can, with experience, you can identify and separate the cavernous malformation from the actual surrounding parenchyma, even though that differentiation, it's not always as easy as the books or some of our experienced colleagues like you to believe. And here, again, carefully pick each one of these small caverns and carefully separate from the surrounding parenchyma, which to some extent is more resistant than normal to traction and manipulation because of the hemosiderin stain and the gliosis. You can see this, I really like this small custom-made forceps with round teeth, and which it's very useful for this type of work, and then careful inspection of the cavity, and you can tell you have removed the cavernous malformation because you are left with a nice smooth cavity. So I hope that I was able to give a little bit of a overview of the different types of spinal vascular lesions, with the particular emphasis on the dural vascular arteriovenous shunts that are by far the most common. And it's really a fascinating topic in neurosurgery because they are definitely not very common. But, you know, with the proper understanding, correct diagnosis, and perfect execution of your therapeutic plan, they can be quite gratifying for the patient and, of course, for the treating physician. Thank you very much for the invitation. Happy to entertain any question.
Thank you very, very much, sir, for this very interesting and elaborate talk. I think it was everyone was so intrigued, and we were able to know so many things and so many points. So again, sir, thank you very, very much. You have said it's a very, very important topic to discuss, and I do think that it is a little bit under discussed and a little bit of misdiagnosed, as they say. It is a vascular chameleon. So many times, like you have already also mentioned in your lecture, that sometimes it is being misidentified, and since the symptoms, the clinical manifestation are in the ascending order, that's why sometimes the spinal level and the level of the malformation does not even correspond. So again, so thank you very, very much. And I think, sir, there is also one thing that came into my mind for many of our junior trainees, that although it is a little bit of rare, but sometimes depending upon their venous drainage, if the rupture occurs, it can also lead to subarachnoid hemorrhage, which can, without any intracranial lesion. I think it is a point of interest for many of our junior residents. So I haven't ever seen this, but we have read about it, that it can be there. So there's also one lesion. Actually, I have read more about it, never seen it, obviously, but we have read about it, the intraosseous spinal epidural fistulas. So I think they are very uncommon, but what's your kind view on them?
Well, your point about subarachnoid hemorrhage is well taken, because you can have bleeding. Usually they are craniocervical junction, dural AV, more commonly craniocervical junction, dural AV fistulas, or they can be subarachnoid hemorrhage, often from a dissecting pseudoaneurysm, usually of the posterior, the posterolateral spine. And these patients, they present with symptoms that are classic for aneurysmal subarachnoid hemorrhage. You do a CT of the head, you might see some degree of subarachnoid hemorrhage, especially in the cisterns around in the posterior fossa. But these patients typically, if you carefully take the history, they will tell you that the pain started in the back first or in the neck, depending on the location of the pathology, and then might have migrated to the head. So when you don't see an intracranial aneurysm, always important to keep a very low index of suspicion and take a careful history. As far as your question about the intraosseous, there is a well-known and characterized segmental type of vascular malformation, part of what has been called the so-called Cobb syndrome, where there is a segmental involvement of the soft tissues, the bone, the disc space, and the spinal canal, including the spinal cord. And as you said, they are quite rare, likely, because those can be quite tricky to treat effectively.
Thank you very, very much, sir. So there's also some suspicion that trauma can lead to this type of formation of spinal, dural, as well as epidural fistulas. Sir, what's your view on trauma being the risk factor for the spinal epidural as well as the dural fistula? And what's your view regarding the comparison, if you compare those fractures which have been treated surgically versus those that have been conservatively managed? What will be the risk in both of these groups separately?
So, the first part of your question about the role of trauma, I think that's very intriguing, and I suspect some of these are indeed related to trauma, because of the characteristic different distributions that we have seen, and also for the dura fistula, the consistent location in a very specific part of the spinal canal. So, of course, trauma, especially when you start considering trauma of mild to moderate entity in the lower spine, it's not that uncommon. So the role of trauma, it's always speculative, but there might be definitely a potential role. The other question is, I'm sorry, I missed the second part of the question about surgery or conservative management.
Sir, I actually wish to know that do you think there is any difference of, if we say that trauma can be one risk factor for this formation of the fistula, would you suspect there is any difference in incidence of or the occurrence of these fistula in those vertebral fractures which have been treated conservatively versus those who have been treated surgically?
Oh, no, I don't know. The majority of these patients, they might have a history of trauma, but usually it's not of severity to result in a true fracture. So it can be a relatively minor trauma, small bleeding gets started, creates a direct AV shunt, and then direct AV shunt over time can grow because the arteriovenous shunt, it's a low pressure shunt, and therefore what it does, it sucks blood from all the surrounding. That's why when we have a dural fistula and AVM, we see this growth around the vessels around it because the low pressure shunt sucks. So I think that's how maybe trauma might act. The same thing, some of those fistulas that are a late complication of surgery, there is often at surgery, there is the history of relatively heavier bleeding at the level of the epidural plexus that has been, it often happens during disc surgery. And with, we tend to tamponade with hemostatic agent, but sometimes you might you might create a very small arteriovenous shunts that eventually they tend to grow over time.
Amazing. So I do also, I do have this thing in my mind that it might be if the person already had this fistula and he might have been suffering from some side of myelopathy that has maybe led to him acquiring some trauma at home. Sometimes we might be receiving those patients with a fall at home, or maybe have hit something, bumped themselves up with something. It may be something that we need to evaluate that before that trauma, whether that person had any sign or symptom of a myelopathy that is taking place, is any gait problem or anything like this. And we also, I think, temporal relationship as well as relationship with the site of injury might be much important in that case, because but that will be something like I'm just a general addition of the comment maybe, but we have to just related temporally and with the site of the injury, whether it's correlating with the dural fistulas. It's a little interesting in there.
Well,
so yes.
Yeah, go ahead.
No, sir, please.
No, I said definitely as the myelopathy progresses in these patients, a history of multiple falls related, as you implied, to the neurological compromise, it's not that uncommon.
Thank you very much. So there are a couple of questions in the chat box. There's one question from Dr. Peter Spasenberg. He's saying that, are you doing post-operative angiograms from spinal dural AV fistulas?
So for spinal dural AV fistulas, if we, as you saw in some of the examples, after you see a few, you go there and you immediately recognize, okay, this is where the fistula is. This is the abnormal draining vein. We do post-operative MRIs. If on the post-operative MRI, I see that the flow voids have dramatically reduced the following day, then I don't do, I rarely do post-operative angiograms nowadays for the true dural AV fistula. In those cases where at surgery, I'm confident that I found the fistula, and post-operative MRI, I see an immediate dramatic reduction or even resolution of the flow voids. That's a pretty good sign that the fistula has been adequately treated. So we don't always do post-operative spinal angiograms in the majority of patients nowadays.
Great, sir. Thank you very, very much, sir. Sir, there's another question from Dr. Donato Cretora. He's saying that, dear professor, after placing a temporary clip, when you use it, after how many minutes do you feel safe? In other words, how many minutes do you want before coagulation of the vessel?
Yeah, the temporary clip, we place it because we like to do a baseline ICG angiography, then place a temporary clip, and then after a few minutes, repeat the ICG and show that there is no early filling of the vein. The temporary clip in this situation, it's on the arterialized vein, so time it's not on an artery, and it's not used like for temporary clipping of the parent artery during aneurysm surgery. Here is more to have further confirmation with ICG that you indeed have found the fistula before permanent coagulation and division. So the time length is not that important. When you do two separate ICG runs, we usually wait a few minutes before we do the second one, just because otherwise you have so much ICG still in the system, then it's difficult to see a true difference.
Thank you very, very much, sir. So there's a third question over here, sir. This is by Dr. Alejandro Martinez Chavez. In one past case, T10 to T11 cyst intramedullary across vessel is spontaneous drainage of the LCR when separate the vessel of the parenchymal wall. In one past case, T10 to T11 intramedullary across the vessel, spontaneous drainage of the LCR when to separate the vessel of the parenchymal wall. I think there is a little bit of typo over there.
Yeah, like it's not uncommon. We come across this all the time. When you have a congestion of the spinal cord for whatever reason, it's not uncommon that even on the MRI, you see congested vessels around it. So in those cases, you have to be careful because unless there is a underlying vascular malformation, unless there is an underlying arteriovenous shunt, those vessels might be bystanders and might be compressed, might look more dilated than normal. And so you have to be, very, very careful. Of course, if you are dealing with hemangioblastoma, then an hemangioblastoma has feeding arteries and draining veins, and the feeding arteries, they need to be coagulated, preferentially during the early part of the dissection. But that's, of course, as we know, it's a tumor with its own particular characteristics. But otherwise, when you have any kind of pathology and you see congested or dilated vessels in the spinal cord around the site of pathology, I would be very, very careful taking any vessel, because that vessel might be a normal but otherwise dilated participant or of the supply or the drainage of the normal spinal cord.
Great. So thank you very much. So there is also something that is more relevant with the endovascular treatment. So in endovascular treatment, they have sometimes mentioned two of important things that they say that we should be very cautious about. And one of them was including that since there is a paramedullary venous plexus for dural fistulas, if we are trying to embolize, we should be very careful. There might be some sort of wedge flow that may lead to relocation of the embolizing agent, and that there might be some risk that you may be able to you may inadvertently put that embolizing agent into the anterior spinal artery. So what's your view regarding that? How can we is there a real danger that we might be able to somehow put that embolizing agent into the anterior spinal artery through that venous plexus or through the wedge flow? Is there any thing that you really think about that could be serious?
Yeah, I mean, it's important to realize that, you know, when you are working under the microscope and you expose nerve roots, you almost always see that each nerve root has a tiny little artery that runs along with it. And, you know, these arteries, they are so small, you can see under the microscope, under high magnifications. Sometimes they go into spasms. You're manipulating the nerve root and might even close off. But what I'm trying to say is that even though we don't see angiographically, there is almost always a tiny little artery providing some degree of supply to the nerve root or to portions of the spinal cord, and they are all interconnected. You know, like when you expose the spinal cord, you see this fine vascular network around the spinal cord that you see only under high magnification. So with the liquid embolic agent, I think that there is always the potential danger that the agent might connect the dots. And if you look at every large series of embolized dural AV fistulas, when they use liquid agent, many series have at least one case of a complication resulting in worsening of the patient function or worse paraplegia. So I think that, you know, for the dural type, it's extremely important to be very, very cautious. As far as the other types of spinal cord vascular malformations, then that's different. For example, the epidural types, it's a high flow vascular, relatively higher flow than the dural type. What that means that the feeding pedicle, it's larger than the one that is feeding a dural AV fistula. So your microcatheter, you can get much closer to the actual point of fistula. The actual point of fistula, it's in the epidural space, it's not intradural. So, you know, there are different nuances. And as I said, and it also always depends on the alternatives that you have available. A dural AV fistula, once you localize it, the surgical treatment is very simple, straightforward. An epidural fistula can be a little bit different. Usually they are ventrolateral to the dural sac. Might be not so easy to expose the full nidus, and the endovascular treatment is very effective and very safe. So it's everything you always have to, the ideal world, you consider the pros and cons of each treatment modality, and then you go with the one that it's safest first when you have alternatives, and then you can make considerations of convenience, invasiveness, and so forth.
And thank you very, very much, sir. Exactly, sir. There was actually a paper where they discussed the presence of the perimedullary plexus that is connecting the ASA with the PSA, the interspinal artery and the posterior spinal artery. They said that perimedullary plexus is so much network is so much profuse, and it could be very serious. It can lead to some sort of inadvertent effects that we are not meant, and like you have very nicely mentioned. I think, sir, the surgery is also a very definite, better cure with a larger incidence of permanent treatment for this dural AV fistulas, which cannot be achieved with the endovascular treatment. So again, so thank you very much. There is another question over here I can see. It was here.
There's one about complications that I can see.
Exactly this one, sir. It is just come in.
Yeah, so the complications, of course, depends on the type of vascular lesions that you are treating. When we consider the most common one, the dural type, one complication could be that you might not have exposed the correct level. So you have to be convinced that you see the typical early draining vein, and if in doubt, you might need to extend your laminectomy. Other complications from the surgery, about 15% of patients can have a transient worsening of the neurological function before they get better. That is maybe related to the fact that as you interrupt the arteriovenous shunt, the draining vein thromboses, and if that thrombosis extends to portion of the venous side that might be draining normal parenchyma, you can make congestion transiently worse. That usually patients after surgery recover at least to the point where they were before the surgery. Other complications, of course, cerebrospinal fluid leakage. A lot of these patients have been decreased activity, decreased mobility for a long period of time. Often they are overweight, so DVT are not uncommon after this surgery. So we are very aggressive with early mobilization. We keep these patients fairly well hydrated, especially the first 48 hours after the surgery. I like to start them the day of surgery on low dose aspirin to prevent, to kind of with the hope of modulating that thrombosis. Since here we are talking about a venous side problem, I'm not sure that makes any difference whatsoever, but definitely makes me feel better. Infections. So, I would say that the complication of surgery for the more common dural AV fistulas are relatively uncommon, and they are the type of complications that you can encounter with every other type of surgery. When you start thinking about cavernous malformation, intraparenchymal AVMs, or perimedullary fistulas, then complications are related to either manipulation or inadvertent compromise of vascular supply of the spinal cord, and those to prevent those complications. For example, for perimedullary fistulas and parenchymal AVMs, the use of intraoperative monitoring and the utilization of serial ICG runs with multiple temporary clipping combined with electrophysiological monitoring before sacrificing a potential feeding arteries. Those are some of the ways that you can minimize the risk of complications.
Thank you very, very much, sir, for this very elaborate answer, sir. Thank you very much for spending time from your very busy schedule to deliver this wonderful state-of-the-art lecture and also for discussion. Sir, I think we have taken a lot of time from you today.
Well, my pleasure. Thank you so much for this opportunity, and happy to be able to interact with you all, and wish you my best.
Thank you very, very much, sir. Honor and pleasure is all ours. And I think it was one wonderful sitting, one of our best sittings ever, because we discussed this topic in a lot of detail with you, sir. And it's like a dream come true for all of us to have this privilege of learning from masters like you, the masters of the perfect subject, and people who are doing this. When I go back and think when I was a resident, I just think that I would read papers from you, and would be like we were so much fascinated. And it's like, for me, I feel so lucky that we now have this privilege of being able to actually learn directly from you virtually, although, but we do have this privilege of listening to you, asking you, putting questions for you, and discussing these things with you, and it means so much to us, sir. So again, thank you very, very, very much. And everyone is sending you a lot of thanks and a lot of compliments. The chat box is quite full, and there are people who are also sending me direct WhatsApp messages in the group that they were so much happy to see this wonderful lecture from you, sir. Again, thank you so much.
Hey, thank you, Maria. Bye. Thanks.
All right, thank you, sir. Thank you, everyone. Thank you, everyone, for joining today. And I have shared the link to download your certificate. Please send me the access request, and I will grant it to you shortly after the webinar. So stay tuned, and I hope you stay connected for our future webinars. Sir, I hope and I really wish to have this privilege of inviting you again for some other new topic, whenever it is convenient for you.
Happy to do it again. Thanks. Bye.
Thank you so much, sir. Have a good day, sir. Thank you so much. Thank you.